I'm Dr. Michael Latola.
And I'm Megan Strong.
In our case of the week, a dentist tries the impossible and sends us a single-unit central incisor.
And a slap shot leads to a snapshot. You'll see our first dental selfie.
And here's our second. Not me and the baby.
No.
Thank you. And worried who's getting involved in corporate dentistry? Well, say hello to Supercuts. That and more on today's Chairside Live. Hey now, hello and welcome to episode 95 of Chairside Live. Megan, 1995, you know what I remember it for?
That I was 8 years old.
That and Denver International Airport opened. That's a big deal for a lecturer who is a million-mile flyer on United Airlines. It meant the end of Stapleton. They told us this was the weatherproof airport. It could never be shut down. It could never get snowed in again. And then a couple years later, guess what?
It got snowed in.
I got snowed in there because the airport was snowproof, but the road leading to it wasn't.
Was not,
no.
no.
So they forgot about that. But anyway, It's been a good airport besides that.
Yes, well, I'm doing well. I think I'm a little off my game, though, today because normally we film on Wednesdays, but now we're filming a day late. What's going on? Where have you been?
I was gone for 2 days. I was up with Dr. Gordon Christensen in Provo, working on some projects together. And the day I got up there Monday night and Tuesday morning before we got started, he had a couple patients that he was seeing. He had been in Asia the week before. And so one of them was like a 75-year-old woman who was having a couple implants placed. She had a lower denture that wasn't very stable. She wasn't happy with it. So he was going to put in some implants, let them integrate, and then put some balls on and retrofit the denture on top of it later. And as he was, it was fun just to watch him work and see him do it. And I kind of tongue-in-cheek said to him, but he thought I was serious. I said, well, where's your surgical guide? You know, because I waited 25 years to start placing implants because I'm a wimp. And when I do it with the surgical guide because I don't want to screw up. And he's like, I don't need those. Nobody needs those. And I was like, well, apparently some people do, like me, Gordon. He goes, no, nobody needs them. And he goes, let me show you how simple it is. And so he numbs her up and just takes. She wasn't the easiest person to work on, too. She was, kind of older. It was hard for her to hold open. But he just slit her open, fillet her open, and free hands these two implants in and nailed it. They were pretty darn perfect, and it was fun to watch. So I get to watch him place implants like a real man instead of
something
like a real sissy
to.
like myself. I don't know that I want to do it. I like the idea of having a lot of technology around these implants. It just needs not to be so expensive, these surgical guides. And that's what we're working on here, trying to come out with a cheaper surgical guide. And hopefully one day we will.
Okay.
We've got an interesting case of the week for you today. We've got a doctor who prepared a nice crown, took a nice impression for a single unit restoration on a central incisor. And he sent along some photographs. There's just one thing missing from those photographs. Let's go ahead and take a look at that. I was walking through the fixed department today and I saw this case, an interesting one of the more challenging ones that any of us probably have to deal with. Certainly one of the more challenging ones for the laboratory. It's the single central incisor. It's a toughie. The dentist did a pretty good job with the impression. As I look around on the facial, I can actually see the margin there. It looks like a little of the stone broke off. And easy to see on the lingual. Little tight there interproximally. We'll have to see when that gets trimmed. How clear we can see it there or not. Interesting. We can really see it on the facial and lingual. We lose a little there. Looks to be nice reduction. Let's look at the mounted models. I keep wanting to turn them over. They look upside down because of this class 3 bite. The centrals are edge to edge, and the lateral incisors are in a class 3 relationship to the lower anterior teeth. He gave us enough reduction, which is nice, on tooth number 8. And he has prescribed a single unit crown here. Now, my first choice for a crown like this is going to be e.max. e.max gives us the best chance of giving you a restoration that's going to match the adjacent tooth because of its aesthetics. It's got enough strength to do very well on the anterior, but on a patient who's got an edge-to-edge bite like this, when a dentist prescribes Bruxer, as this dentist did, I agree with that too, and I have no problem with that. It's just going to be a little more challenging to make that crown match the adjacent tooth. In fact, one of the things that I find really helpful in cases like this is to do a no prep veneer on the tooth next to it. And, I learned this in an interesting way. Since I practice inside of Glidewell Laboratories, I get all my restorations for free, as well as a hot lunch every day. And when I got restorations for free, it became clear that all of a sudden I could do certain things. Like if I was doing a single unit crown on a tooth like this, I could also ask the technician for a no prep veneer on this tooth. And oftentimes I would try in this crown, and the patient, I would look at it and we'd say, yeah, it looks okay. And then I'd say, wait, let me try something. And I'd put the no prep veneer on this tooth and we'd look again, and the patient would say, wow, that looks a lot better. What did you do? And because now these two teeth match all of a sudden. Then I started doing it the other way, where I would try in, I say, let's go ahead and take a look at that. And I'd put in the crown and the no prep veneer without saying anything and give the patient the mirror. And they'd say, wow, that really matches well. That looks great. And apparently they'd forgotten what that tooth looked like, because now they just loved how much those two teeth looked next to each other. And they say, that really looks good. And I say, okay. And I say, let me hold on a second. And I'd go in there and I'd take this one out. I'd take out the no prep veneer and leave the crown. I'd say, go ahead and look one more time. And they'd look and they'd say, oh, now what happened? I'd say, well, actually, here's what I did. We made a veneer for this tooth. And I thought of it after you were here, and I just had to make it because I wasn't sure if you'd like it or not. So if you want to, we can put it in. But if you don't want to, we don't have to put it in. And so, because obviously there's no shots or drilling or anything at this point besides luting it on, and the fact that it almost always makes that tooth disappear, or at least assures that it's going to match this one because they're both made at the same time from the same material, 9 out of 10 patients said yes to it. Sometimes if we were doing 2 teeth, I would make no preps for these two. Sometimes it would just be for the bicuspids if it was a case where we lost the buccal corridor because it had been restored to the cuspids previously or something like that. But jokingly, when dentists ask me what's the best way to restore successfully a single central incisor, my answer is to put a no prep veneer on the one next to it. But that wasn't done in this case. It wasn't presented to the patient, although it would be fun just to make one for this doctor and send it along for free and give him a heads up and have him report back and see how it does when he tries that into the mouth. So in order for us to make a crown, certainly a Bruxer crown, but even an e.max crown that's going to match the tooth next to it, we're going to need a photograph. There's really just no way. I mean, just imagine that you're the technician trying to fabricate this crown, and the shade on this is a D2. So we've got a D2, and that's really all we have. We have an impression of this tooth, and really, so we're just going to do a D2 and kind of match the shade guide and assume that's going to be able to blend in with this. So we're going to need some photography, and the dentist actually sent in some photography, which is a great step in the right direction. And so again, you can see how our centrals are edge to edge, our laterals are in crossbite, and you can see how the tooth number 8 has fractured already, possibly, potentially, because of that edge to edge relationship. And so here's tooth number 9 still edge to edge, and so a Bruxer crown there I don't have an issue with. The problem is this dentist owns a camera. That's not the problem. But he took a photograph that's essentially useless to us or useless to our technicians because there's not a shade tab in place. And so the variability in color from camera to camera and printer to printer if it's not emailed, or even monitor to monitor if it is emailed, there's so much variability that without a shade tab in place to compare the shade of tooth number 9 to, unfortunately this picture, while it might be useful for something having to do with surface texture or some other sort of characterization, it doesn't help with shade at all because we need a reference. A D2 shade guide would be nice. We'd prefer to see the shade tab with the patient open. He did take a picture. It's slightly blurry, so we're not going to be able to get that one in focus. But with the patient open like this, we would take a shade tab and we would put the incisal edge of the shade tab up against the incisal edge of the tooth in the same plane, so we wouldn't want the shade tab towards the uvula or out in front of the tooth. We want it incisal edge to the incisal edge in the same plane so that when the flash hits both of these, it's going to hit it just as hard. So in the same plane, incisal edge to incisal edge, make sure you don't cover up the D2 or the A2 with your thumb. That's another one we see about 10% of the time is the doctor is conscientious enough to take a photograph with a shade tab in place and then covers up the name of the shade tab with his thumb, or the assistant does, and then it's kind of difficult as well unless we can call them and they remember what it was. So with the shade tab in place, even if it's a D2 and it doesn't really match, what it allows us to do is now we can see the shade of the tooth and the shade of the D2 in the photograph and see the relationship between the two. So they might look at it and say, you know, the tooth is not quite as gray as the D2, and the value is actually a little bit higher. So then when our technician is making the brush or crown, they will take a D2 shade tab out as they're doing the staining and glazing and continue to match it to the D2 and go, okay, I need it to be a little less gray than this with the value a little bit higher, and get that same relationship between the crown here and the D2 shade tab here as we have here. Otherwise, this really doesn't do anything for us about where it is, and the chances of this being a dead-on D2 are just not that likely. So this doctor did such a great job of doing a good prep, reducing enough on the incisor ledge, reducing enough everywhere, getting a good impression with the margins, and actually taking pictures. The only thing that's missing is the fact that we don't have a shade tab in here as well. So I'm going to call the doctor and tell him we can go ahead and proceed with the crown at this point. But if I had to put a number on it, I'm going to say there's maybe a 50 to 60% chance that if we just made the crown now, that the patient would like it enough to be able to cement it. But I believe if he were to get the patient back and get a photograph with a shade tab in place, those odds are going to go up to 85 to 95% that we're going to be able to match the shade well enough that the patient's going to be happy with it and be able to cement the crown that day and be done with it. Of course, we could also do the no prep veneer on the one next to it too, if he's interested, which I do like to do. Although I can see, it's something to bring up to patients and ask them about that if they want to. Again, keep in mind that most of the teeth that we restore, because we as dentists have a tendency to under-prepare teeth because we're conservative, especially on the facial, like on these anterior teeth. Since we have a tendency to under-prepare and technicians have a tendency to overbuild in the name of aesthetics, teeth have a tendency to grow. And it's pretty predictable, almost 85% of the time in the last study that we did. When we measure teeth after they have a crown put on and then measure it using CAD/CAM technology against a scan of the original tooth before it was prepped. So for example, if we took a impression of this central incisor of tooth number 8 here, and we took an impression, poured it up, put it in a scanner, and then measured the facial lingual thickness, and then the doctor prepped it, and the crown was cemented into place. We took another impression, poured it up, scanned the crown. The facial lingual thickness of the crown here, on average, would be 0.2 of a millimeter thicker, 2 to 3/10 thicker than the original tooth. And it would all be on the facial. It can't grow to the mesial or the distal, and it can't grow to the lingual. And that's why a 0.3 of a millimeter no prep veneer on the adjacent tooth looks so good next to a tooth that's been restored with a crown, because the crown will usually increase in size on the facial surface by 0.3 of a millimeter. So not only does the shade now exactly the same between these two teeth, but now the tooth that's been restored with a crown doesn't look too bulky, too fat on the facial, because now both of them have been increased by 0.3 of a millimeter, and they both match now in terms of size and contour and shape as well.
Now let's go to a segment we call the YouTube Comment of the Week. This week's YouTube Comment of the Week comes to us from Dr. Timothy Huckabee, and he writes in and says, he commented actually on Chairside Live episode 94, which was last week's, and he wrote, "Dear Dr. D, what scanner is your lab seeing the best optical impressions? Please don't say CEREC, not a fan."
Oh,
no.
hashtag sorry, not sorry. Well, Tim, let me put it this. Oh, hold on. Oh, Serrano, yes. Not a fan of Dr. Huckabee's either. Oh, interesting. Little controversy brewing on the show. I like to see that. Well, Tim, it's a really good question, and it's one that I'm going to. I'll share some numbers with you in just a minute, but it'd be kind of like asking, in a sense, which impression material works better, like which brand of impression material works better. Am I better off going with the one from 3M or from Kerr, or the one from Ivoclar? And as anybody who's practiced for a while knows, it's really not the brand of impression material, and it's really not even if you choose polyether versus polyvinyl siloxane that makes a big difference. It really comes down to the operator, how they're going to treat the tissue, how they're going to do their isolation, how much retraction they're going to get, are they able to keep the field dry, and all those types of things as well. So I feel the same way about digital scanners. The impressions that I've seen that have come in from dentists, whether it's the iTero from Cadent, we're starting to get now impressions from the Trio scanner from 3Shape, or the Cerex scanners that are out there, and there's quite a few of those out there. Or the ones that are coming in. There's actually a bunch of different ones popping up now. The True Definition is on its second generation from 3M SB. And so all these impressions come in, but as you look at them, you see some good ones with each system, and you see some, at times, not so good ones from each system. And so it seems like it's more dentist dependent than it is which brand of technology you go with. Certainly the brand should be influenced by whether or not you ever plan on adding a mill at a later date, although there's more and more systems that will allow you to add a mill at a later date in case you want to expand and actually start providing chairside crowns, which for me is the ultimate utilization of these techniques. But until we're able to really get a technology, and I don't think it's going to be with any of the current laser scanners, it might be ultrasound technology, some sort of technology where when we do a scan, we're able to see through the tissue, through saliva, through blood, and it can differentiate between tooth structure, between bone, between gingiva. Then we've got something. Now we really have something that's kind of a game changer, and it's kind of right now still a dream. This technology doesn't exist. But that would be something where all of a sudden we could start to say, that brand, whichever one it is that comes out with this technology, if they ever do, is the one that's really going to put you head and shoulders above. That being said, let me pull up a few numbers for you here. I apologize for blacking out the names of these companies, but it's just not going to do anybody any good if I show you the names of these scanner companies, because again, it all depends on which dentists are using these. And this would be like if I showed you a graph saying, here, hey, look, the Ivoclar material has less remakes than the 3M. Do we really think it's about the different brands of polyvinyl, or polyvinyl versus polyether for that matter, or is it the skill of the operator? So as we look at these numbers from left to right, you can see there are some differences. I can tell you that the one on the right, that's the lowest margin and fit remake, and that's what this is, by the way. This is for all of last year. This is the remakes in terms of fit. So either the margin was short, the crown was too tight and it didn't fit, something. So shades taken out of this and things like that. This is doctors returning crowns to us for a remake because it didn't fit or the margin was short. And over on the right, you can see the one system that has the smallest amount of remakes that also had the smallest amount of digital impressions sent in. So you have to wonder, well, was that something statistically that caused it to be the lowest in terms of remakes? And it's not one of the more popular systems that's out there. And so you wonder, it's not a huge difference when you look at the difference. But on the second chart, what I want to show you is in the midst of all these scanners, I want to drop conventional impressions in here. So this is all the polyvinyls and all the polyethers that we received over the year. And again, this is just kind of margin and fit. We tried to take everything else out of it. And you can see the conventional impressions kind of slot in between those two. So it's really not statistically a huge difference between any of these systems. And I don't know that there's a clear winner. If there was a clear winner, I feel like there would be a lot of purchases going on for one system versus another, and we really haven't seen that. We've seen kind of the same amount of growth coming in from the different systems. So, Tim, I really feel as though it really doesn't matter. I mean, I have no doubt that if you can take a good impression with polyvinyl siloxane, that you could take a good impression with any of these digital impression units. It really kind of comes down to, for me, when it comes down to high technology like this, which company do you want to work with? Who's going to service this when something goes wrong with it? Because it tends to happen with high technology. Who do you think is going to provide the most upgrades for you? Can you add a mill at a later date? What do you think about their integration with different systems, with different or modalities, whether it's implants or orthodontics or things like that? Really, to me, that's where the decision kind of comes in. I'm sure you'll find one company who'll say, oh, we're 20 microns more accurate than this other one, but those are difficult things to kind of prove, and I don't know that they're clinically significant. So we, in fact, if we did this again for this year to date, we might see those different brand names that I didn't show you flip-flop and go in different directions. We see this happen a lot of time when we look, if we narrow the time period or lengthen the time period. All of a sudden, if we're looking at remakes of shade, Bruxer could go higher than PFMs or lower based on whatever might happen to happen in any kind of period of time, these statistical aberrations. So, Tim, I really feel that if you're taking good polyvinyl impressions, any one of these systems will work for you. It really kind of comes down to which one you feel the most confident in. Hopefully what we're trying to do here, we're doing a pilot program right now where dentists who send us a digital impression, if it comes in, say, before 3 p.m. our time, we can design it and mill it, stain and glaze it that day, and it's ready to ship the next day back to you, and it'll be in your office on the third day. And this is a big belief of mine that, 2-week dentistry as we do it now, where we prep the crown and then deliver it 2 weeks later, nothing good happens during that 2-week period. We've got a leaky temporary on where it might be slightly out of occlusion and the contacts aren't great. Nothing good happens. I don't even know where the 2 weeks came from. My best guess is we know that the average American gets paid every 2 weeks, so we're going to let them get another paycheck so they can pay us for the second half of the crown at the seat appointment. Otherwise, I don't know where it comes from. Nothing good happens during that 2 weeks. The best crowns that I've seen in terms of fit are the ones that I do same day, but I cheat. I've got a technician on site who makes it for me, so I don't have to become the lab myself. So I understand there's a big investment to do same-day dentistry, and you have to change your office around a lot. But what if instead of taking 2-week dentistry and going all the way to same-day dentistry, what if we took 2-week dentistry and went to 3-day dentistry? I've done that, and what I've seen is less adjustments, less remakes, less post-operative sensitivity, less endo, just all kinds of good things happen when we don't have that leaky piece of plastic, the temporary in place, any longer than we absolutely need to. And even if you were still going to schedule people 2 weeks out to cement the crown, if their temporary came off after 4 days, you could have them come into the office that day and just put the permanent one on as well. That's part of the promise of digital technology, is us being able to get restorations back to you quicker. The faster we get them in the mouth, I absolutely believe the better for the patient. Also, you save us a ton of work. We don't have to pour any models and section them, pin them, articulate them. And that's why we give doctors $20 off on, say, Bruxer and e.max restorations when they send us a digital impression instead of a conventional impression. So that was a very, very long-winded way to not give you a really good answer to your question about which brand is the best. I don't think there is a best. I think it all comes down to the doctor who's using it, how conscientious that doctor is, how good the prep is, how much they care. There's a great quote from Bill Strupp, one of my clinical mentors, who says, a crown and bridge impression is nothing more than a measure of a dentist's integrity. And I used to disagree with that back when I was taking cruddy impressions. Right. Now that I'm using, what I like, the 2-chord technique, I'm getting much better results, and so now I agree with that because my integrity levels come up a lot in the last 12 years. So
Wonderful.
Thank you, Tim, for writing in. That's a great question. I know where you were going with that, but really just pick the company that you trust the most, and I think you'll happy with your choice if you believe in that company. So, Megan, what do you have for Tim for being the YouTube comment of the week?
Well, hello, Tim. It's your lucky day.
Uh-oh.
Here we go. Get ready. We had such success with this photo last week, that we're bringing it back out again.
Oh, it was. It was the Chairside live recursion.
Yes.
It was, since we couldn't show the Hasselhoffian recursion.
Which is a good thing.
It had, according to the legal department here, 40% too much chest hair.
Okay.
But it was close, but 40%.
Ew.
When it comes to chest hair,
that's wrong. I think any percent is probably too much.
And you wanted to give Tim a mug.
I did want to give him a mug.
And we're temporarily out of them. So, Tim, this one's for you. Here's your mug.
That's disgusting. I wouldn't trust it.
Tim's got an autoclave. Tim's a dentist. Tim's inhaling patients' saliva all day long.
Okay, now that you mention it, I think it's fine.
Yeah. If Tim's old school, you can take a crown and stick it in his hand, and he won't. You say, wait, let me put a glove on.
Oof.
That's me, though. That's really old school. He might be younger than me. I'm not sure. All right. Thank you, Tim. You got any news?
I do. What if a dental office operated like a chain coffee shop? Think no appointments, menu-driven services, and out-of-pocket payments. The founder of Supercuts, the chain hair salon, is developing a chain dental concept. His prototype store is in Michigan and is called Super Teeth. But when he launches the brand nationwide, it will be called Great Teeth and will start in Kentucky. He says the brand is targeting consumers who don't regularly visit the dentist. He believes that the clientele need 8 basic services, like checkups, fillings, extractions, and that a menu with fixed prices is a simple way to deliver just that. Enter shock here.
Wow.
It's like you go to the corner coffee shop, you go get your haircut at the corner salon, and then you go get your teeth fixed.
We used to hear, there used to be rumors that chains were going to start doing dentistry. There was a big rumor for a while that Costco, you know how they have optometrists inside,
yes.
They do eyeglasses, they were going to put dentists in there with CEREC machines, and they were going to prep your tooth. You were going to walk around and spend $370, the average at Costco,
right.
And then come back and get your crown on, and then walk out, and they would check your receipt, like they do with the magic marker, and then mark on your crown on the way out to prove that you had paid for it. And that was supposed to happen. That never happened. There was a chain of Sears stores, I believe in Michigan, in that area, where there was actually dentists inside of Sears. We keep hearing this is going to happen. Costco, I bought into, because and who knows, maybe it still will, because they've proven they can do anything they set their mind to, and they do it with optometrists, but that's a little different. That's not nearly as invasive as an injection and having your tooth drilled on. Mm-hmm. The last thing I expected was Supercuts to get into it. That or maybe Domino's Pizza to get into it, but Supercuts. So he was going to call it Super Teeth. Now they've already downgraded it to Great Teeth?
Yes.
How long will it be till they're at Good Teeth?
And then mediocre, and then okay.
Yep.
Yeah.
And then then awful teeth.
Right. Then awful teeth. Yeah, I don't know. It's very interesting to me, like, just as a consumer, prior to even working at the laboratory, that would never appeal to me.
But you know what? Think of all the stories that we've done on unlicensed dentistry being done.
Home-based dentistry.
There was just another one, a woman doing orthodontics out of her house. And it turns out she was an assistant. She used to be an assistant, so she knows just enough. And she was having 10 patients a day come into the house, and she was putting on brackets and doing all that, doing ortho, essentially. And there's so much of that. We've done so many stories about unlicensed dentistry, and it's clear that the people having this done are having it done for some reason besides they're seeking out the highest quality. And I think in a lot of those cases, it's probably cost. Sure. So for them, it would probably be a huge step up to be able to go to Great Teeth, formerly Super Teeth, and
instead of
have this
somebody's
done.
Laundry room or basement.
Exactly.
Yeah.
So I think if they're going to serve, and frankly, that's a part of the population that a lot of dentists don't want to have to deal with, like if they have a plan, like a very cheap state-sponsored reimbursement plan. Most dentists say, "Oh, we don't accept that," and these patients don't have anywhere to go. And so if they're able to kind of fill that niche and serve those patients, it's probably a good idea.
That'd be really good, and that makes me sad that some dentists wouldn't do that.
Yeah, and it's just. Yeah, you get paid almost nothing. I mean, to do a crown, to get paid $100 instead of $1,000, it's I mean, you might be able to do that every once in a while, but it's hard to accept that. Yeah. And so, a few dentists accepted that all those patients end up at your office too. Right. Any word on whether or not you can get a haircut there while you're having your tooth work done?
I don't think so. I think that they are completely separate. But some people brought up the point that maybe it wouldn't really work. The model wouldn't work because a lot of people want to have that relationship with their dentist and know them well. And just like as at a Supercuts, when you walk in, you're not, since there's no appointments, there's no whatever, you may get one dentist this day, another day. And so that was another concern, that they wouldn't have that rapport between patient and practitioner.
I bet if 40 years ago or 50 years ago, if you would have told an average American couple who were used to going and seeing their doctor that one day there would be urgent cares,
right?
That were open 24 hours a day in some cases, where you would go in and see a doctor you'd never met before and get worked on, they would have said, well, who would do that? That doesn't even make sense. So maybe the same way that we've seen in my lifetime, I've seen the rise of these urgent cares.
Sure.
And there's times where you've got kids, it's 3 a.m, they've got a high fever, you got a choice. An emergency room for what might be $10,000, $15,000, $20,000 if you're not insured. Your doctor's not, you're not calling your doctor and waking him up probably, because you don't have his home phone. He probably has a service, but whatever. Urgent care is there, urgent care is open. and you do it. So maybe this is part of a new model like that, if for nothing else, for people waking up in the middle of the night with toothaches, who usually go to the emergency room where they don't know what to do with them, and they're kind of like, we don't treat toothaches here.
Sure.
So if it was just for that, for nighttime emergency toothaches, it would definitely serve a need.
Yes.
Anything else?
Yes. Hockey is a dangerous sport. Sure, it doesn't pose a big concussion risk like football, but it can be pretty brutal to a player's smile. Mitch Callahan from the Grand Rapids Griffins knows that all too well. He suffered a fractured jaw, 10 lost teeth, and a bunch of stitches, all from a slap shot. He was quickly escorted off the ice by the team trainer and underwent surgery the next day. Once he was off the ice, Mitch took to Twitter and posted a gruesome picture of the damage, spreading quickly around the world.
No, I haven't seen this picture yet. I know you put it on the laptop.
Get ready. I know, we have all of our viewers, or most of our viewers are dentists, and so they're used to the bloody mouth sort of thing, but this is next level.
Well, we don't try to see that much blood.
Okay.
I mean, it's from you guys not flossing where most of the blood comes from. Not you in particular.
Thank you.
Do you have pregnancy gingivitis? I haven't even asked.
No.
Oh, you don't? Well, it's hormonal. It's
I
not from
don't.
being a scumbag. I know.
Right.
I'm glad you don't. It's not a value decision.
Okay.
You could brush your floss 3 times a day, and some women get pregnancy gingivitis.
Not yet.
Okay. Well,
Please don't.
Here we go.
Okay, ready? I'm going to plug my ears.
And the Oscar goes to... Oh, that's pretty brutal.
Yeah.
That's
pretty bad.
No, there's not a lot of dentists who've seen that in their office unless they're the team dentist for the...
Okay, of course, but I'm just saying they're used to seeing bloody...
Only a hockey player would take a selfie like that.
Oh, yeah.
I mean, that's...
And his concern was, he just said he didn't know how many teeth he had lost because they were just falling out.
Right.
But his concern was that he wasn't going to be able to go back and play.
Right.
And the trainer was like, no, you are not playing anymore. You are going. So
That's a tradition in hockey that you go in and get stitched up and come back again.
Back out,
yeah, I mean, you don't see that in a lot of other sports. And you don't see people taking selfies like this. I don't know if he would have done this or the average person would do this if it was in a car accident or something like that.
Gosh,
but
probably not.
It's pretty brutal. His lips kind of split.
Yeah, the lip is the biggest thing for me. That's just really oof.
I wonder if that'll be like a popular Halloween costume this year. I saw another one that I liked. I don't know if you've seen this one.
Oh no, I'm scared.
No. This was another one that started to go viral. This was a girl at a dental office who took
I don't think I want to see
selfie.
it. Oh,
No, it's totally different.
Oh, that's funny.
Yeah, that is funny. It's especially funny because she's on nitrous oxide.
Right.
So she is absolutely
So she
high
thinks
as a
it's
kite
hilarious.
right now. Oh, she doesn't look at her eyes. I mean, she's not even trying to make her eyes look big.
No.
And I don't know. She maybe she's freaking out. She saw what the rubber dam looked like when you have that on. You have that whole lower arch like that. So I don't know what she's having done. Probably, I don't know, the molars on both sides, so they just put the entire rubber dam on. And that's something we used to do in dental school all the time. A lot of people, when they graduate, stop doing rubber dams.
Yeah, I was going to say, I don't think I've really ever seen...
You've never seen that before?
No.
Well, in dental school, it would take us close to... We saw patients in 3-hour blocks, and it would take about 2 hours and 40 minutes to put that on. And so you were like out of time, and you tell the patient, do you mind wearing that home?
Right.
And let's just start with it on tomorrow. The other funny thing was there was so little parking in San Francisco where I went to school that the meters would start to run out every 30 minutes. So patients would have to go out every half hour with this on and go put, and so people who drove by the school thought it was like an insane asylum.
Right,
they
what's
didn't know
going on?
what
People are escaping.
some kind of medical experiments were going on. And she put the little caption, I laughed more than I should have.
That's hilarious.
And that's the great thing about laughing gas. So I don't know what she's having done, but she had a good time. So hopefully this will start a trend of people taking selfies, dentally related. You know, whether they're happy ones like this or grotesque, bloody ones.
I was scared. I
like
thought you were going to show me something just gruesome and worse than Mitch's photo, but that's funny.
You want me to look for something?
No, I don't actually. Thank you.
Remember that time when we did look up something that kind of grossed you out?
Yeah, how can I forget?
We were looking up those growths. Yeah, we'll leave it there.
Thank you.
All right, you're welcome. That about wraps it up for this edition of Chairside Live. On behalf of myself, Megan, the CSL crew, and everybody here at the lab, I want to thank you for your time and your continued commitment to quality dentistry.
We'll see you next time. My belly button is getting shallower.
Right.
And I'm like,
Are you finding lint that you didn't know was there?
No.
Oh.
But I'm like, oh my gosh, does that mean that it's on its way to push all the way out?
Go.
No.
There must be an Audi. We gotta get a picture of it.
Late
no, we
in
don't.
the middle of the night, you're just going to hear.
The only thing I could think about the whole time you said San Francisco was sourdough bread. I just couldn't.
Like Homer Simpson.
An abutment that he provided.
Oh, yeah, doctor provided the abutment. Ooh, that'll be a good continuity one for the buffs.
Right. I was going to say, where's the script supervisor? Because...
That's you.
Touche.
I mean, it's from you guys not flossing where most of the blood comes from.